Hello, friends, and welcome to Thinking Clinically. My name is Dr. Lilian Kadiri. Just a few days ago, I submitted my MSc dissertation in internal medicine at the University of Edinburgh. For the past year, I've spent countless hours reading, researching, analyzing data, and thinking about a question that affects healthcare professionals all over the world. Why do so many intelligent, hardworking clinicians fear neurology? As a clinician myself, I've seen this fear firsthand. Students feel it, interns feel it, even experienced healthcare professionals sometimes feel uncomfortable when faced with neurological patients. This phenomenon has a name, neurophobia. Today, I would like to share what neurophobia is, why it matters, and what my research taught me about helping clinicians become more confident in neurology. So let's start. So, what's neurophobia? Imagine you're an intern on a busy ward. A patient arrives with weakness on one side of the body. Someone asks you to perform a neurological examination and explain where the lesion might be located. Suddenly, concepts like cranial nerves, motor pathways, sensory tracts, localization, and differential diagnosis start racing through your mind. For many clinicians, these moments create anxiety. That anxiety is what educators often refer to as neurophobia, which is a fear or apprehension towards neurology that makes learners feel overwhelmed with neurological consent and patient. The term neurophobia was introduced in 1994 by American neurologist and educator Joseph Fovich, in which he attributed it to be a result of failure of students to integrate basic sciences with the clinical sciences, resulting in the anxiety around neurological assessment. So, around the world, people still say that neurology is difficult when you compare to other specialties like respiratory medicine. So, why does neurology feel difficult? Probably because it's complex in itself, that integrating neuroanatomy and clinical presentation can be very difficult. Doing neurological examination itself takes a huge amount of time, and having to elicit the signs and symptoms that are going to point to where the lesion is can be difficult. However, neurology may not be difficult because we're not smart. It's probably difficult because there are very many concepts and it's complex and it needs to be conquered a step by step. So, neurophobia really matters to us, especially in the sub Saharan context, where we have a lot of burden from neurological conditions, yet we have very few neurologists, meaning general health practitioners have to treat patients with neurological conditions. So we need to work very hard to address this fear of neurology so that front care healthcare workers can treat patients effectively. This is what happens. So a patient comes to you with a neurological concern, maybe a headache, and you start with the assessment from the history taking to elicit what type of a headache it is, then it's an emergency, a dressing, or something that can be explored further. So as you're taking the history, you are thinking on how you're going to design your examinations. And you're thinking clinically, trying to interpret what do this symptom mean? If it's an acute, it's a chronic, or it's maybe even a symptom of another illness that is not neurological related. Then once you have done that, you design different lab or imaging investigations that are going to guide you towards a likely diagnosis, possible differential diagnosis, and also to rule out other differential diagnoses that do not fit in the picture. Then now once you have the diagnosis and the differentials, you design a treatment and you come up with a monitoring plan. Could be an admission, could be to go home and come back in a short while. And when we address neurophobia, it means clinicians will have confidence from the patient assessment, history taking, examination, clinical reasoning, ordering the right diagnosis, and tailoring the right treatment for the patient. Let me take some time and talk about my research journey. I was doing this research as part of Masters in Internal Medicine at the University of Edinburgh. I did this research while working full-time as a clinician at Nanyuki Teaching and Referral Hospital, where I supervise medical officer and clinical officer interns and occasionally nursing officer interns. I designed a mixed methods research, which had both a quantitative aspect and a qualitative aspect. For the quantitative aspect, I was measuring four things. That's neurophobia, self-reported confidence, knowledge, and skill assessment. Knowledge assessment was done using multiple choice questions per cadre curriculum. Skill assessment was done by senior medical officers and a senior nurse practitioner using an OSCE style method of assessment. For the qualitative data collection, I used a semi-structured interview question where I picked 3 nurses, 3 clinical officers, and 4 medical officers and asked them questions so better to understand their nature of training when they were in school and their nature of training at internship and how they influence neurophobia. If they were able to talk of what they felt helped them elevate the fear of neurology and what factors also worsen the fear of neurology. So after collecting both the quantitative and qualitative data was analyzed separately. For the quantitative data, it was analyzed using SPSS. Well, for the qualitative data, there was thematic analysis where recurring themes were grouped together and even quotes were collected to put weight to what interns were able to say. After doing separate analysis, data was integrated to make the findings more sensible. Here are my research findings. Quite interesting, actually. For a start, neurophobia was very prevalent among medical officer, clinical officers, and nursing officer interns with an average score of 65% for all cadres. There was a strong relationship between neurophobia and confidence in an inverse way. The higher the neurophobia, the lower the confidence. However, neurophobia was not related to knowledge, nor the skill. Knowledge was related to skill. Of note, which was quite interesting to know, is the weak relationship between knowledge and confidence, in that learners may possess knowledge but still lack confidence to apply it effectively in clinical practice. These findings suggest that improving knowledge alone may not be enough. Learners also need opportunities to practice, receive feedback, develop clinical reasoning skills, and build confidence through supported experience. In other words, confidence and competence are closely linked, but they're not the same thing. What are the lessons for educators from this study? Number one, we need to provide opportunities for deliberate, safe, and repeated practice. We need to offer feedback in a timely manner that is constructive and that guides reflection and growth. We also need to provide a supportive learning environment by creating a safe, respectful, and encouraging space for learning and questions. While reflecting on the findings of this research, I came up with one simple conclusion that neurophobia is not an inevitable consequence of neurological complexity, but a modifiable educational challenge. If we teach better, support learners better, and create opportunities for meaningful clinical practice, we can help healthcare professionals become more confident, more capable when caring for patients with neurological conditions. Thank you for joining me for the first episode of Thinking Clinically. In future episodes, we'll explore clinical reasoning, medical education, neurological assessment, professional development, and the journey of becoming a better clinician and educator. Until next time, Keep thinking clinically. Thank you.